Home movies capture the vibrant spirit of a young teenage girl, but behind the smiles, life for Gypsy Blanchard and her mother Dee Dee is one replete with hardships and challenges. Gypsy is in a wheelchair.
Something never felt right about it. Just Dee Dee was so controlling of her.
This isn't your ordinary medicine cabinet. It's Dee Dee's personal pharmacy.
The organization of the medications was shocking to me because in every other area of Dee Dee's life, it appeared that she had absolutely no organization or cleanliness, except when it came to these medications. It let me know from the very beginning that something here was seriously wrong.
The famous case of Gypsy Rose and Dee Dee Blanchard is a perfect example of the seriousness of factitious disorder and factitious disorder by proxy, and how vitally important the treatment of this disorder is. This disorder has implications leading even to death, but unfortunately, the treatment has been unsuccessful and untested in the past. Before looking at treatment and implications, I will show how Dee Dee Blanchard and those with factitious disorder got to where they are. First, it is important to note the difference between factitious disorder, Munchausen syndrome, and Munchausen syndrome by proxy. Often these terms can be used interchangeably, which is incorrect. All three include a diagnosis from the DSM-5, including 2 or more instances, including lying about physical or psychological signs or symptoms of an illness, induction of injury or disease, and use of deception. This deceptive behavior occurs even without obvious external rewards, and the behavior cannot be explained by other mental disorders. Where factitious disorder and factitious disorder by proxy differ is that those with factitious disorder present himself or herself as ill or injured, while those with factitious disorder by proxy impose injury or illness on others. Munchausen syndrome is considered the most dramatic form of factitious disorder, in which people use different identities to travel from hospital to hospital in order to deceive doctors. The methods of illness falsification include exaggeration, fabrication, simulation, and induction. Some examples of these can include faking lab test results and faking medical records. This deceptive behavior leads to excessive medical intervention. Those with factitious disorder often complain about problems with pain or medications. Other characteristics include a close relationship with local doctors and immature behavior with staff or family and friends. Diagnosis is important because factitious disorder leads to excessive medical intervention that is dangerous because it is unneeded and expensive. Diagnosis of factitious disorder needs to be carefully considered because if a doctor decides to approach the patient with doubts about the realism of the disorder, the relationship between the patient and physician will most likely be damaged. The diagnosis is difficult because oftentimes medical records are faked or inaccurate. The patient can underestimate the amount of visits to a hospital and which hospitals they have visited, so the information on the medical records cannot be easily verified by other doctors. The way doctors can become suspicious about a patient possibly having factitious disorder is noticing inconsistent lab results, noticing that physical findings do not line up with reported symptoms, and the patient has not responded to any medical treatment. The biological factors of factitious and Munchausen disorder are difficult to define because most of the research is outdated and unspecific. A study done in 1987 by Pankratz and Lezak showed the possible role of cerebral dysfunction in Munchausen patients. Results show that out of their participants, 1/3 of them had deficits in conceptual organization, although these results may not be generalizable to current day because this study is 30 years old. In 1992, Babe et al. Found abnormal brain functioning images in a Munchausen patient, but this was only one patient in one case study. Psychological factors have been difficult to define, but one might be a person's intention and capacity to deceive others. A patient with factitious disorder is often more likely to have been in the medical field in the past, so they would have the knowledge and skills needed to be able to create the fake illness. In addition, some have a childhood history of parental illness, death, or abandonment. It is theorized that factitious disorder could be a learned coping mechanism to these events. The severity and longevity is affected by if a doctor can catch the factitious disorder. The more the disorder goes unnoticed, the more the patient's behavior is perpetuated. Factitious disorder is also comorbid with substance abuse, adjustment disorder with depressed mood, malingering, borderline personality disorder, and atypical personality disorder. The prevalence of factitious disorder is unknown because of the large role of deception as a major characteristic. The DSM-5 predicts that among hospital patients, 1% of individuals could meet the criteria for factitious disorder. The onset is usually early adulthood, often after hospitalization, and the course is often in intermittent episodes. The prognosis can be severe, leading to death because of the risky behavior of the patient with excessive medical intervention, although some patients end up stopping their behavior. Unfortunately, factitious disorder lacks sufficient evidence for a successful form of treatment. One form of unsuccessful treatment was creating a blacklist of patients with factitious disorder. This would tell the doctors in emergency rooms who to treat and who not to treat. This treatment is now considered unethical because it denies healthcare service to certain people and would stop those with factitious disorder from receiving psychological help. Other unsuccessful treatments include the let them have it ideology, in which a doctor just allows the factitious behavior. Discussion also arose about whether confrontation should be used by doctors in order to treat factitious disorder and what level of confrontation is appropriate. Confronting a patient in an accusatory way is not recommended. Vigorous and repeated harsh confrontation will just drive patients to another hospital or doctor. Doctors should build a relationship with the patient, and hopefully, once the relationship between doctor and/or therapist and patient becomes strong enough, the patient would admit their deceptive behavior. Effective forms of treatment are difficult to accomplish, but what does work seems to be psychotherapy. This is difficult because very few patients with factitious disorder would agree to psychotherapy. In 1989, Eisendrath introduced 3 alternative forms of treatment to confrontation: inexact interpretation, therapeutic double bind, and face-saving techniques. Proper treatment might not occur because doctors are hesitant to diagnose factitious disorder. The balance of evidence for diagnosis and treatment is difficult. When a doctor requires a lot of evidence to diagnose factitious disorder, patients could continue to undergo risky, expensive, and unneeded medical procedures. When a doctor's threshold of evidence is too low, patients can be diagnosed incorrectly and confronted unnecessarily when faking their real illness. Treatment outcome can be better when a therapist waits for the right time to reveal that they believe the illness is factitious. This time is hard to find, but is best when the therapist believes the relationship is strong enough. Some of the implications of treatment of factitious disorder include legal and ethical issues. In the past, the paternalistic model of medicine was accepted, which allowed doctors to do anything to establish a diagnosis. Doctors could search a patient's room without their knowledge to find evidence of a factitious disease. This model is no longer considered ethical or accepted by the medical community. Another implication is the risk of alienating someone who does not actually have factitious disorder. And even if a therapist or doctor has correctly diagnosed factitious disorder, this could be humiliating for the patient. Then, the patient will be less likely to accept treatment or open up during therapy. Future research needs to include larger groups of subjects. In addition, future research needs to show which characteristics of patients lead to them agreeing to psychotherapeutic treatment. Treatment for factitious disorder is extremely important because it can save someone from undergoing excessive medical treatment, but treatment is rarely reached because of the deceptive nature of the disorder and the patient's unwillingness to admit to the factitious disorder.